We are live.
Okay. So good evening, friends, and good evening to all the members of All India Ophthalmological Society, and welcome to this webinar series on behalf of Academic and Research Committee of All India Ophthalmological Society. Today's webinar credit goes to our member ARC Center, Dr. Deepak Mishra, for crafting this particular webinar, particularly for younger lot of All India Ophthalmological Society members. This is basically for the young people who pass out from their residency and then they are having a big question mark ahead of them. What next? For what next? What are the choices? What are the options? We have this particular webinar for you. Let me ask Dr. Deepak Mishra to carry forward the proceedings, who has crafted this for the betterment of all our members. Over to you, Deepak.
Thank you, sir. Good evening, everyone. As sir already mentioned, that this session has been crafted just for the young ophthalmologist and for the resident who just passed or in the final year to know what are the various examinations and their certification courses available nationally and internationally. To guide us through this journey, we have a galaxy of esteemed speakers. Each of them have their own experiences, huge experiences you can say, on this topic. And before we dive into the main session, I would like to invite the chairpersons to say a few words to set the stage for this one. First, Dr. Lalit Verma, sir.
Thanks, Deepak, for having me here as part of this very important. You see, ARC team, I'm so impressed by Dr. Prashant Baunkule for continue to, carry this torch of, education, teaching. And I think every day he does some activity or the other. And already, one of his program has already crossed 1 century around 2 weeks back. So I did wish him that you have already such an. So in any case, this particular concept of beyond residency, a lot of people do not know. Because yesterday only, after the operation theater, I was sitting with one of my fellows, and this lady from Bihar, I think Patna, was not much aware of kya kar sakte. See, this is very important. You see, AIS FICO is one part. Then there are so many other things which can be done. And Rashmin is pioneer of these things, and I know I have heard him also. So many things today can be done. So remember, our basic aim is to improve your credentials so that, professionally you're not found wanting in your career. Aim is that, if in the formative years, that means immediately after PG, you are exposed, at least these things can be done. So depending on your zeal and depending on your skills and excellent this thing, you can pursue this. And believe me, the more you learn or the more qualification you have in these years means somewhere around from 27 to 35, I think you can keep improving keep adding those, genuine degrees. Otherwise, people keep adding those MFI, so people don't understand other languages. So, but genuine degrees or so-called can be added, and believe me, this will improve your profile so that not only you excel, your job placements become easier, and also your emoluments also tend to increase. And believe me, after 32, 34, 5, it's very difficult to crack, because you are now fresh in your knowledge exams very well, and you can take. So that's what I wanted to congratulate the ARC team, especially Deepak Mishra, for this concept.
Thank you, sir. Dr. Rasmin Gandhi, sir, you are the first person who helped me in making all the framework. Sir, few words from your side.
Thank you, Deepak. And as Dr. Lalit sir said, I think ARC, Dr. Prashant has been doing some wonderful webinars, and it's really a pleasure to listen to all these stalwarts who are here. I remember long ago, I was coming back from Baroda with Dr. Lalit Verma sir in a flight. And at that time, I realized that those days webinars were not really the thing, but the physical teaching and the kind of ideas that he had thrown at that time, every sentence had some innovative ideas about teaching. It just shows that, we are so fortunate to have all these leaders who are passionate about teaching, about sharing knowledge. And I think we are seeing the fruits of these younger generation who is really becoming very good. So I wish Deepak, thank you so much and all the best for this webinar.
Thank you, sir. Our ARC chairman, Bhavan sir.
Yeah, I have already spoken. So thank you, Deepak. I don't want to make you more fat by adding few more, adjectives to all the efforts which you have done. But thank you once more, Deepak, for creating such a wonderful webinar along with Mamta. Now you can carry forward.
Thank you, sir. Now I invite my co-moderator, Dr. Mamta Sinha, to invite and start the actual proceedings. Dr. Mamta,
Thank you.
please.
Yeah, thank you, Dr. Deepak, and good evening to everyone. Thank you, Prashant sir, and the entire team ARC for this wonderful opportunity. And so with this, we are now going to start the session. And we are really honored to have Dr. Lalit Verma sir today with us. He's a veteran in the field of ophthalmology. More than 40 years of experience with him. And this is very much reflected with the number of publications he has, the awards, the honors he has received. And he's associated at present with CSF Delhi. And currently he is the chairman of FICO committee. And I believe that there cannot be a better person to talk on about this topic. So welcome, sir, and over to you.
Thank you, Mamta, for these kind words. I'll, with your permission, share this screen and just give me a hint that this is visible, that's all. So,
Yes, sir. Your screen is visible.
Okay, thank you. So once again, thank our chairman ARC, Dr. Prashant, for this concept. And the reason I said yes to this program when Deepak rang me up was because, as Mamta was saying, more than 40 years, but the passion for teaching and learning does not go away. Because teaching and learning both are, twin brothers. In fact, once you teach, you learn also. So they're intertwined. So thank Deepak also and Mamta for being, instrumental in having me here. This session to me looks very, very exciting and very thrilled to know that 8 speakers, will be delivering some very, very useful talks. And Deepak always has been in the forefront of education teaching. I remember during COVID days, his zeal, enthusiasm, he used to ring up at that time. I was chairman scientific committee, and he used to ring up, "Sir, ये वाला करना है, ये बच्चों के लिए फायदा होगा, ये होगा." And he was instrumental in a lot of publications also at that time. So, congratulations, Deepak, for that. I still have fond memories of those things. So, the key question today, as soon as a person finishes his post-graduation, whether it is MD, MS, or even DNB, is what next? What next and why? So because you see, there are some people who will have clear concept by zindagi mein ye karna hai. And those are generally, kids of the entrepreneurs and big hospitals. But a vast chunk of our people are still not aware or maybe aloof or they're not exposed to such things. So you see, what I'm trying to say is that they do become an eye surgeon. Legally, in the court of law, as soon as you finish your DNB or any post-graduation, you are qualified to do starting from chalazion to RD surgery. You can do that. You can, no judge will catch you with tumne ye vitreous surgery kyun kiya, but you have that qualification. But is it a fact today? Is it a reality? The reason is because I conceived this idea of FICO in around 2009. I remember sitting in Chennai along with Dr. Babu Rajendran, who was my president at that time, and I was the treasurer, and Dr. Azad was the secretary, honorary secretary of AIUS. Sitting in that hotel, sipping a cup of tea in Dr. Babu's room, we thought we should do something for AIUS. And the seeds of this were sown primarily when I told Babu that a couple of days back, one of my patients asked me, "Dr. Sahab, आप retina surgery की degree है आपके पास, आप qualified हैं retina करने के लिए?" So that actually woke me up. अरे ये क्या हो गया? So you will not believe it. Next day I ran to RP Center and RP Center could not. So, but in any case, I requested Dr. SP Garg, who was there. So he gave a small this thing that Dr. Likarma was here as a senior resident in veterinary department. That's all. And so this, we thought, then I actually, you will not believe it, I approached Nirman Bhavan. I spoke to the secretary there that we should have some super specialization. Then I approached, because Dr. Azad was chairman of DNB board also at that time. So मैंने सर को request किया, मैंने कहा sir, we should do something about the super specialty, because patients today are very much aware, thanks to, you know, the world being flat in this internet era and Google knowledge so much that people are asking for these things. So Dr. Azad, believe me, at DNB, as president of DNB, he started, I think, super specialization in retina as and one more specialty. And Delhi mein Gangaram and Shankar, Natarajan's place was made, you know, and even Chandigarh made, you know, super specialist centers. So that was the genesis. So this FICO, people who are not aware, stands for Fellowship of All India Collegium of Ophthalmology. It was variously named previously, but finally we stuck to this term of Fellowship of in All India. As of now, this is primarily for AIS members, but soon, you know, I'm taking this concept to international bodies also, primarily Nepal, SAARC countries, as well as Australia. I've already spoken to their leaders, and there is an enthusiasm in this. So why FICO? The basic aim, as I said, was to encourage and standardize knowledge. You see, aim was that whether you get operated in Jaipur or maybe in Chennai or wherever, there should be a uniform standard knowledge and skill in all the ophthalmic specialties. So with this concept, we started in 2009, but ultimately implementation took some time. And this was the initial brochure, which a lot of people may not be aware, which I had published at that time. This ultimately got implemented. I remember myself standing in that you know, exam in Janakpuri, where you know, I was super you know, vising this examination, and Mr. O.P. Gupta of AIS was there, and he too was along with me. So today things have evolved quite a bit. The subsequent secretaries, presidents have done a lot of hard work, and everybody has recognized. Initially, there was some resistance by the subsequent office bearers, but everybody has now you know, taken the positives of FICO, and we are doing since 2010 and doing this standard examination. So, but we thought, what will happen to people like P.N. Nagpal, H.K. Tiwari, who already are so much this thing. So for them, we introduced this concept of honorary FICO, which again, you know, we split into two by nomination and selection. Selection was on the basis of the years of service as well as on the basis of CV. You see, remember, the basic aim of FICO was to you know, certify that this gentleman is, or is this madam is qualified for, you know, delivering an average you know, care for that particular specialty. But the bulk of this thing is by examination. So FICO today has three components. Remember, I told you in the beginning, I went to Nirman Bhavan, you know, so many times, but they said concept is very good. But if we take ophthalmology, we'll have to do for so many other specialties. So you do submit an application, which I did, but ultimately didn't hear from them. Because my aim was that it should be certified by the university. So till the time, you know, these people wake up, we thought we'll, at least AIS level, we'll start giving this certification. So FICO by examination, I'll just dwell upon a couple of points. This is primarily, as of today, awarded in 10 specialties. So we have glaucoma, retina, vitreous, uvea, and then we have NTS7 cornea, cataract, refractive surgery. Also included pediatric ophthalmology, strabismus, oculoplasty, neuro-ophthalmology, and comprehensive. So these are the 10 subjects, super specialist, where AIS gives FICO award. Remember, there are a lot of discussion and how many times, because I remember one AIS member in Calcutta, he has taken FICO virtually in all the subjects. So, but then we put a limit that a member can apply for one specialty and he can do maximum 2. You see, it's very difficult today that a person is very good in oculoplasty and retina also. So generally not possible. I know younger generation today does it, but a super specialty, conceptually, our board said that this is the maximum you should be doing. Then the FICO for national level, he must be an AIS member definitely, and he should have this basic person qualification, any of these And minimum of, initially we thought 1 year, but later on modified to 2 years of experience should be there after completing his postgraduate, so that he knows and he's interested in that particular specialty. 1 year initially we had started because that was the initial takeoff, and we thought a lot of excitement may not be there, but excitement gradually increased. So we revised to 2 years experience so that that particular member understands the nitty-gritty of that specialty and is sure that he will continue that specialty. So we laid down 2 years of experience. Other eligibility points were that he should have completed the, for 18 months fellowship, or residency is variously called, and also must have 3 years of, practical work in that specialty. So for this, we had to have some cutoff date because initially we had not put. So September 30th of this year, of any year whensoever you are applying. So this year, September 30th will be taken as the cutoff date for fulfilling this 18 months and 3 years period. So this process involves two components, this examination. One is an online test because obviously we can't hold it, physically everywhere. So we thought that if at one particular place we have, say, more than 10 people, we will have a center there. So recently I approached, Nepal and Australia. I told them that if you have so many candidates, we will have a center there also. And the second component is OSCE and Viva. Most of the weightage, is given for written test. And OSCE and Viva just to see that person physically, and we have specialists in that particular specialty to question and see whether that gentleman or a lady can actually do that specialty. Aim is that once he is into practice, he should be able to deliver, whether plasty, retina, squint, or whatever. He should deliver the average standard of care which is required of him. And as of now, we are AIS is doing this online written exam in 6 of the centers, but AIS is always open that we can have more centers depending on the demand. So we create an epicenter in New Delhi. So neighboring states like Haryana, UP, these people can come in New Delhi. Similarly, all these metropolitan cities were included. And OSCE and Viva, we hold different specialties, like we may choose SN for retina, then we may choose, glaucoma ke liye Shiva Eye Center, depending on which we want. So those candidates are required to travel there. The other thing we were very particular was that we never wanted, like Deepa says, sabko pass karna. Aim of FICO was that we did had some level of toughness, that 50% of questions we said must know, itna to basic aana hai. Then level of difficulty 25% moderate, and 25% was difficult question which differentiated between the topmost and the average student. But one thing we had heard is no negative mark in this. Then question bank, initially I created question bank which is still there, but Santosh Honavar and this front team, they are adding questions every year. And for this new question bank every year is added, and we do hold a FICO meeting for all these examiners and keep adding these questions. And these questions, believe me, are vetted by the board also. This is not that they say and we take it. And the examination process is at one go in all the 6 centers. And it's a 1-hour exam. And there are 100 questions, MCQs. Some are situation-based, some are, choice-wise. And pass marks, definitely at that time, I think it is still adhered, is 70%. Anybody who scores, as I said, the top, this thing is given, weightage is given to the online, because we wanted maximum subjectivity or maximum objectivity there. So people who clear this online examination, they are called for OSCE examination and Viva. Initially we had some difficulty because some people could not travel, or some people had some emergency. So we included this clause that if a candidate has cleared stage 1 but is unable, to travel or or qualify also in stage 2 or 3, he is given one more chance without taking the written exam. How to apply? I think detailed instructions are available at the website of AIS, and you can see that. And there's a fee for that. And because we have to hire, this Meditrack, and there are a lot of companies who, do examination for us. And this fee is payable by, they sent to AIS office. This demand draft is payable. And these are the last dates. This is specifically for this year. I copied from the AIS website. that July 31st, recently, gone by date. And this is the, examination centers. And we declare the online result definitely in this month so as to be prepared for OSCE Viva. And finally, before the next AIS conference annual is held in January, we declare the final result. And these candidates then are awarded at a special function in AIS conference. So this was thanks to the work done by Dr. Namrata and Dr. Grover, who was the chairperson at that time, because a lot of people were asking, what is the curriculum? क्या पढ़ाई करना है इसके लिए? So this, booklet is worth reading. It's available on website also. That what kind of syllabus. Actually, this syllabus is your post-graduation only, but this listed in a big way about the various specialties. This has more than 200 pages. So this will go subject-wise. This will tell refractive surgery mein what all is expected from you. So if you open refractive surgery, they will tell you what all you should be knowing. So this is taking some time to load, but rest assured, this is there on the website. Initially, we did collaborate with ICO just to add some weight to the FICO. But since they wanted their name to be there, and we were very particular, the leadership at that time, because the idea was ours, and we wanted that AIUS ka naam rehna chahiye. So because they were except putting their name, they were not helping much. So gradually, initially they started with cornea, then neuro-ophthalmology, but ultimately we only said, because they were only putting a tick only and said ICO AIUS. So gradually they were weaned off, and today we do not have any collaboration with ICO. ICO itself got split into two bodies, so we did not. This slide is just to show you we started in 2010 and how many people, gradually, if you see, the enthusiasm kept increasing. And in 2023, we had 288 candidates who appeared. The pass percentage also, if you see, started with around 20 or 30%, has now gradually increased also. And this year data is still, to be compiled. Last year, which was the 15th examination, we had a phenomenal 429 students who appeared for this examination. Coming to my last couple of slides, where I entered FICO by nomination for very senior people, where we nominate. Nominate means the top professionals in their super specialty. We, the board sits down, and everybody gives names from the region or this thing, lest anybody important and missed. So for these very, very senior people of the caliber of Nagpal Tiwari, Badrinath, Daljit Singh, all these very senior people who have contributed so much to ophthalmology, NAM, everybody. So I personally approach these people, no fees charged to them. So this, at least they should have 20 years of obviously experience of teaching as well as membership also. And no CV is required for this, because the board on its own makes the selection. And after selection, the respected member is then requested to send his CV for record purposes. The third category is FICO selection, where they are intermediate people, somewhere of the category maybe of Deepak Mishra or you are in between, who are not very, very senior, but they are senior enough for FICO. They also have some years of experience. And for this we call CV, and for this they have to apply also. And this, a particular number, initially they were 5, then as and through the increase, we increased to 10 fellowships. So they have to definitely prescribe on a form on or before 30th November in that respective year. And this is available on web. This is the form which I was talking about. You have to fill up a one-page form only and send it to Santosh Hanawar, the present secretary. So this was the FICO board, Azad as emeritus chairman, and a lot of renowned names, including Tanuj, Prajna. Aim was to have a representation from all the, my aim always has been use C formula. We have some people from north, east, west, south, so that we have a good representation. Like Somshila we included, and Dr. Sucheta, Sunita Dubey, the president, secretary, treasurer, NEKs are there as ad hoc members. So this is Deepak. I just wanted to share my views of FICO and its importance today. And I wish and hope maximum number of members utilize this. Believe me, this does carry some weight that you're a super specialist, and AS does award a big certificate to those people who qualify, and they proudly hang it on their wall also. Thank you very much, Mamta and Deepak, for this opportunity.
Thank you, sir. Thank you so much for giving us the background story and for bringing such a beautiful idea, something to go with Make in India concept, something that we all can be very proud of. And I can see the buzz it has created among, all the postgraduates. They all are actually waiting to go for it. So thank you for that, sir. And thank you for your time, sir.
Thank you so much.
So next we have Dr. Rohit Saxena from RP Center Delhi.
Before we move to the next presentation,
Yeah, please.
we will take a brief comment from Rohit Saxena, sir.
Yes.
Sir is already a FICO awardee. Sir can.
Yes. So thank you. Sir actually had highlighted the dilemma we have as, professors also of RP Center, where there is no certification of a super specialty or a subspecialty, as you may call it. So FICO that way has really come in handy for us to be able to showcase that we are trained and we have adequate ability to treat these patients, particularly when it comes to very complex surgical subspecialties like refractive procedures, glaucoma, retina. So it becomes very, very important. And I think now, because subspecialty has become an essential component of any practice, whether it's in an institution or private, I think it's essential that we all of us start aiming to certify our ability and experience with the FICO.
Thank you, sir. So next presentation is going to be by Dr. Rohit Saxena, and sir is working at RP Center, New Delhi. He is regarded as an authority in the field of strabismus, and he's a master in aligning those deviated eyes. And sir has an extensive experience as an examiner, as a mentor, and he knows exactly what a postgraduate teacher is looking for. So he is the person who is going to talk about cracking the code MS and DNB examination. Over to you, sir.
Thank you very much, Dr. Mamta, for the introduction, and of course, Dr. Deepak, Dr. Prashant, Dr. Lalit for the opportunity. So I'll be talking about MD, MS, DNB, and of course, before you actually start dreaming of a FICO degree in subspecialty, you need this and a couple of years of experience before you can actually think about that. So we'll talk about MD, MS, DNB, because more or less your preparation is similar to all of these exams. Sorry, I think my slide is, I'll just reshare it. I thought my slide was not.
It was not moving, sir.
Yeah.
At the first slide itself.
Yeah, now it's moving.
Sir, we are still at the first slide. Yeah, now we can see the next one.
Okay. So I'll be just, the contents would be planning about.
Sir, if I can interrupt you, there are some windows that are open on your screen which are blocking the view. So if you could close those.
There is only this, which I'm not sure.
Yeah, if you could push it to the side, maybe we'll be able to see the entire slide.
Hide floating, right. Yes. Okay, better?
There's still something there at the center now.
Go into the full screen, maybe we'll.
Yeah.
I'll just go to the full screen. Are we okay?
Yeah, better. There's still something in the bottom right, but much better.
Okay. So this is the overview of my presentation: planning, studying, notes taking, theory, practical. First, of course, the most important thing is start early. You need to plan your exam. Like any exam, you need to build up to it. You need to have a plan in place how you're going to do. So the planning would be, of course, to familiarize with the format, both for theory and practical. Each requires a separate kind of an approach. Make a list of the syllabus specialty-wise. Take your previous year questions and divide them into subspecialty, and then gather all the required material from colleagues, from the internet, each specialty wise. Remember, because each subspecialty has a lot of depth and width, You need to study specialty wise, but think comprehensively. That is the actual way for studying for MDMS. Go deep in every subspecialty, but have an open mind so that you can shift from one topic to the other, because so many disorders can coexist, like cataract and glaucoma, with diabetic retinopathy, with ocular surface disorders, with maybe some blepharitis. So the questions can come from anywhere. And if you are kind of focused only in a one subspecialty when you're presenting, or you have a mind block for others, thinking that this is all that's going to be evaluated, you can be in for trouble, because you have to actually remember to be able to think on your feet, which is the best way to answer in a practical exam where you have questions coming to you directly. Of course, make a study schedule, stick to it. Time just flies. When you start your preparation, say 6 months ago, you think 6 months is a long time. But when you start dividing them, that I have 6 months, 1 month will go away because I have my thesis submission to make. Subsequently, I divide into subspecialty wise. So retina, should I give 1 month? Then glaucoma, 20 days. Then cornea, again 20 days. When you start dividing, you realize that retina, you have only 1 month. And you list out all the topics you're supposed to read in retina. And you suddenly realize that you don't have the luxury to read CRVO only for 3 days, trying to understand its pathophysiology in depth. So you need to then think that in those 30 days, I'll go through the course in 20 days and go for my revision in 10. So again, you have only 20 days and maybe 50 odd subspecialty topics to go through. So then you start realizing that time is the luxury you don't have. So a schedule, plan it, stick to it, divide days at the beginning of each subspecialty, and create timelines for each. The reason for timelines is that there is no doubt you will overshoot them, but that will create that slight mental pressure that drives us and pushes us. Otherwise, all the pressure comes in the last 2 months, and then you are kind of flapping your hands and you're not sure what to do. So when you create these divisions, you realize that the pressure can be uniformly distributed and give you a chance of managing your things. Like I said, list topics, list topic wise, pick topics once you've read them. You can use online platforms to help you coordinate or remember, or a note that you have already covered it. And the most important thing, again, when you're dealing with MD, MS, DNB, have a case-based format. It's important because, one, the tougher part of the exam is the viva and the case presentation. Theory, you still have time. You can use recall to answer your questions. You can use the horizontal thinking that we were talking about to answer questions. But when you are standing and and somebody is shooting out questions at you, you need to really be fast. So if you have prepared in a case-based format, have a flow chart as to how you are presenting your case, you cover everything and you don't forget, like systemic examination in diabetic retinopathy case. So when you're writing up a long case, anything about, say, diabetic retinopathy, you can start at the very beginning that systemic examination is important, control is important, look for peripheral neuropathy, look for non-healing ulcers. So these are important. And again, go in a flow. Do on that topic, you can use a standard textbook, or and cluster topics together, because concepts may transfer from one topic to another. So vascular occlusions can be completed in one go. However, it becomes monotonous, you can intersperse with some different small topics so that it keeps up the interest and you don't get kind of bogged down by a lot of one type of a thought process. Take breaks. Remember, it's just not for patients, the 20-20-20 rule. It's for you also to not to have your eyes getting tired or your brain getting bheja fried, as the concept goes. So take your break. You can even, a couple of days are not good days for studying, so don't press yourself. Don't hard press yourself that I have to do. If it's a bad day, just take a break, go see a movie, chat with friends. You come back with that increased pressure and renewed energy. Meditation, adequate sleep cannot be overemphasized. It's very important. Sleep helps the brain to put the information in the places it belongs to, and again helps you in rapid thinking, on your feet thinking. Always note the source, because sometimes you may be asked where you read it from. Just like this. So strabismus, you have these certain books, remember where you read from, and finally in the end you're only be going to read from one small set of notes that you're making. So again, make notes, handwritten or digital, whatever is your preference. Highlight important points. Wherever there is a picture available, read that. Visual memory helps. Practice drawings and charts particularly in frequently asked topics, so that you can reproduce them easily and you're not thinking and wasting time or recreating a chart or trying to make sense of it and then cutting and making it in rough and then going final on in your final answer sheet. So practice your drawings, have a visible picture. Again, it helps to answer long questions. Theory, I mean, like I mentioned, revision is important. Eat, sleep well. Just before the exam, have a decent breakfast. A lot of your answers you'll remember are recall based. In the last 20 days, it's unlikely that you would have read more than 2 or 3 of the 10 questions asked. You're going to sit back and dream what you read a month ago on the topic you did not think was important. A couple of questions are going to come like that. Have a decent breakfast. Too heavy or too light, either hypo or hyperglycemia is not a good way to appear for an exam. In the theory exam, divide your time. If there are 10 questions based on the marks, plan it. List out before you start plan your answer sheet that this question needs a diagram or a flow chart or a table. Answer in a logical flow. Don't randomly run between clinical features and investigations and then back to another feature that you missed. Leave space a little so that you can go back and add. Keep 10 minutes always in the end for revising, and do not leave any answer even if you don't know anything about it. Just write anything you can think about it, anywhere related. At least you will get a couple of marks. If you don't write anything, no marks are possible. Even a very lenient examiner just can't write anything. Neat writing, highlight words, make them as clean as possible, because a tougher to examine paper is a lesser given mark paper. But again, every exam is a little different, but usually you are divided into the various topics. So you need to plan again accordingly, although there is a lot of overlap, but plan your paper accordingly. Your revision and your thought processes have to be accordingly. Discuss under subheadings if they're existing, and of course, stick to point. First 2 questions you've taken more than an hour, and then you are struggling to reach for the last 8. So it's again important to time. DNB a little different. There are 10 questions of 10 marks each, fixed limit number of pages, timing. So again, planning for a DNB answer sheet is far more important. Practicals, memorize the performer of presenting a case. If you keep presenting while you are practicing, again, that's why the case-based approach to learning. You should be able to present a case, summarize it, practice writing the case how it is appropriately written. And if you have the luxury of a ward round in your examination, in your workups, remember or recall questions during the ward round, which will help you. And of course, basics. If you don't answer a basics question, you can fail. If you don't answer an advanced question, that's still pardonable. Again, during the exam, be careful. Don't jump to a diagnosis and try to fit your findings to that. Write a list of differentials, summarize before you walk in for presentation. Be able to justify the diagnosis. Your diagnosis may be wrong, or your differentials may not completely cover the final diagnosis, but it should flow with your workup and your investigations. And of course, carefully answer questions, because the next question comes from the answer you've given to the previous question. So if you do not know something, go around it, tiptoe around it, or bury it in a stream of statements that you're making. Otherwise, the next follow-up question is exactly on that where you left your answer for. Elaborate history, proper systemic examination, refraction, go sequentially, advise appropriate tests. If you cannot do them, list them out, that I wanted a visual field, I want an MRI, I want this test, I want a specular, even if you don't have it, because that will show that you know what is the next test to be done. For diagrams, make them, mark them properly. Short cases, only relevant history, quickly jump to what you are supposed to see. Write positive findings and mention the important features on the paper, what you've looked for, and important negative features which are helping to lead to your diagnosis. Spotters, don't waste your time or anything. Just go to the thing that you are supposed to see. If you want a confirmation and you think a history can help you, then you go back and ask a couple of questions to help you. Otherwise, do exactly what you are supposed to see and list that out. Finally, the most difficult part, the viva. Answer to the point, go, don't jump around. If you do not know, admit it so that you have time for the next question. You hum and haw, you go around it. The person, examiner is asking you a follow-up question, thinking that you may answer it, encouraging you, and you waste a lot of time, and a lot of your questions, other questions which you knew don't get answered. Do not mention anything you don't know or won't be able to give a follow-up question on. Divide your answer again. Go sequentially so that you don't forget either anterior to posterior or most important differentials. And again, be confident of your answers. Examiner may just try to confuse you or try to give you a different option. Remember, whatever, if you're confident, often the examiner will accept it and move on forward. The most important, again, that means you have to be confident, and before you enter, you need to summarize so that you know what you're talking about. Thank you very much for the opportunity.
Thank you, sir. Thank you so much for such a wonderful talk. It was so practical and so fluid. It's like living those moments again and again. And I especially like the
I
part.
hope not. I never would want to.
Yeah. I like the part when you said don't leave anything blank, because I remember I had a 10 marks question in my DNB examination on Badal's principle, and I had no idea, absolutely no idea. But I wrote 3 pages on that. I don't know what all I had written. Over to you, Deepak, please. Huh?
And another thing, sir, your comments on the hypoglycemia. That is the most important. I usually remember in my UG days, most of the times we go directly without breakfast, and at the half of the time it looks like when the tea or the coffee anything came for the examiners or the invigilators, then kash ek mujhe bhi mil jata.
I thought that was just me. Sorry. We all are spilling the beans, it seems.
Really, these are the small things, but usually we missed in the exam, and it hampers the result either in writing or even in the Viva a lot. Means how you prepared well, not only in the text wise, but your dressing sense, your whatever the behavior and your body language, everything is very much important, both in the theory and the practical. Rasmin sir, one brief comment from you, then we invite our next speaker for that.
No, I really love the way Rohit covered the entire gamut of what is required for the Indian exam. And I also liked his comment to Mamta saying, oh, hopefully we should not be any.
Yeah, that was a good one.
Thank you. Thank you, Rohit.
Yeah. So up next, we have Dr. Devendra Venkatramani from Lakshmi Eye Institute, Maharashtra, a prolific vitreoretinal surgeon and a passionate academician. And he's going to guide us through the nuances of FRCS examination. And with his first-hand experience, I'm sure we all are going to be very benefited. So over to you, sir, and welcome here.
Dr. Mamta, one thing I would like to add about Dr. Devendra sir, he and Rasmin sir is doing 2-3 days of the great mentorship program on his place on this such type of examinations. And I really suggest those who are willing to do or take this exam must visit at least once in his program schedule whenever he is planning.
Are these details available online?
Yeah, I'll be sharing those details
Sure,
at the end of this. I hope my slides are visible.
Yes, sir, visible and perfectly audible. Yeah.
Thank you for the kind introduction, and thank you, Deepak sir, for those words. We enjoyed Dr. Rohit's talk. It brought back memories of our days. But there are certain things in common whether you're giving Indian examinations or foreign examinations, and I'll just go through some of these, the nuts and bolts, as it were, of the FRCS examinations. Now there are different royal colleges, and there are each of them has their own set of rules and sets of examinations. But the Royal College of Physicians and Surgeons of Glasgow, as it is known, is the one that is probably the best known and the one that's most relevant for ophthalmologists who are based in India and wishing to enhance their portfolio of degrees, as it were. If one is based in the UK and looking for a licensing examination or looking to migrate to the UK, then the Royal College of Ophthalmologists examination, that is the FRCPath, based in London, is probably the important examination to look at. But I'm going to restrict my talk to the FRCS from the Glasgow College. Generally, this examination has parts which you have to clear stepwise, like with other international examinations. The first part encompasses basic sciences and optics. Now, in the FRCS, you have to give both of them together. So you have to appear for this paper, which is a 2-hour paper, which comprises of 160 MCQs, and those are roughly equally divided into 4 parts: anatomy, physiology, pathology, and then there's a group including optics and refraction. So this is the first part of the examination which has to be completed. And then you are eligible to appear for the clinical science paper, which is again an MCQ paper. In the past, this used to be again divided into two subparts, and the one subpart would have you to write essay type answers, but that has been done away with. Now these are online examinations where you have to appear for a single paper with 180 questions and 2.5 hours duration. So here a lot of the the actual clinical ophthalmology is being tested, and there is this entire spectrum of disorders that you would be quizzed upon. Glaucoma seems to be topping the list with almost 10% of the questions, but there are certain rare disorders that you would be quizzed upon, including general medicine and medical emergencies at the bottom of the list. If you look at it, account for about 11% together. And other subsections which one would probably have thought of leaving for option, as it were, in Indian examinations are going to be tested in these exams. So you need to know at least the very salient, important parts of those disorders as well. The third part is divided into two, and the first examination or subpart is the structured oral examination, which we colloquially call the vivas, and the second part is the clinical examination where you would examine patients. The structured oral exam or the viva is again divided into three tables where you have examiners quizzing you on these different subtopics, and the clinical examination is similarly divided into 4 different stations. So we'll talk about that in a little detail later. But when can you give these examinations? So the first exam, the part 1, you don't really need to even finish your ophthalmology training. That is, you don't need to have completed your MS or DNB. Your primary qualification, which is your MBBS, followed by 1 year of internship and 1 year clinical experience in any field, makes you eligible to appear for part 1. So I strongly recommend those who are appearing for either the FRCS or the FICO, as it were in the past, you could do it during the course of your MS and DNB. That's an excellent time to learn basic sciences and optics and refraction, and you're not burdened with too much of clinical reading at this point. Part 2, however, needs to be done after you have completed your MS DNB and when you have at least 54 months after your MBBS, 5 years after your MBBS, of which 54 months should be in clinical ophthalmology. And once you complete part 2 or you have an exempting qualification, you can appear for part 3. The fees are a significant area of consideration because these are expensive examinations, and there was a little bit of a respite in the year 2016 to 18 when the pound was devalued after Brexit, but unfortunately that has bounced back and the exchange rates are not very favorable to an Indian candidate. And now subsequently, because the examination including part 3 is being offered in India, you are now also eligible to pay 18% of GST on top of the examination fee. So the overall amounts really add up into lakhs. So there is a significant amount of financial planning also that goes into these exams. And as the website says very optimistically that you have 6 attempts for each part, but I'm sure that you would be exhausted mentally, physically, as well as financially before you reach those attempts. So I would strongly suggest your first attempt is your best attempt and make the most of it. This is just an illustrative table to show you that there are different locations and dates for the exam, especially the third part, where you may need to travel. There are centers in India, including in Delhi and in Mumbai, sometimes in Chennai or Bangalore. So you'll need to look out for these, and that would involve some amount of traveling and stay and other logistical sort of planning on your part when you appear for this. The exam itself is the third part itself is about held over a course of about 3 days. So you would have to take that time off to actually go and appear for it. All of these details and more are available on the official website, that is rcpsd.ac.uk. So go through each and every document that is uploaded over there so that you are in no confusion and you have no regrets later on and no surprises later on. International examinations follow this Angoff technique, which is a very interesting way of examining candidates. Basically, in a nutshell, the questions are divided into groups, whether they are difficult or easy, and as a cumulative average, the paper is assessed to determine whether it's an easy paper or it's a difficult paper. And appropriately, the pass mark is either lowered or raised. It would be low for a difficult paper and high for an easy paper. So it's a floating pass mark. So it's not like an Indian examination where you have to hit 70% or 50%. You won't really know what is the pass mark until you get your result, and then you would know how you have fared as per, in proportion to the pass mark. So let's look at how you really prepare for the exam. The first part, which is optics, I would strongly recommend the textbook by our late Professor Dr. A.K. Khurana, The Theory and Practice of Optics and Refraction, which is very comprehensive. But a little shorter version is the manual by Elkington, which is also excellent for a good revision. For the basic sciences, the textbook by John Ferris, which is solely on MCQs with their answers, is indispensable. And there are also other voluminous texts like the one by John Forrester. So good reading of these would give you information, knowledge, and something that you can apply even into clinical practice after the exam. For part 2, which is focused on clinical sciences, I would recommend nothing more than your MS or DNB syllabus as reading material. For self-testing and evaluation, you can use this excellent review manual by Jeffrey Lampkin and co-authors, which has, again, MCQs, which are quite difficult to solve, but luckily for you, they also give the answers, so you know how you're faring overall. So this is a good book to self-assess your progress. And for emergency medicines, the Oxford Handbook of Clinical Medicine has a section on emergency medicines. Essentially, you would need to know about different situations which you would encounter even as an ophthalmologist. So there's no excuse that as an ophthalmologist we need not know these things. As a qualified doctor, you are you're already well versed with this kind of management, and you should be into clinical practice. This is how they basically enlist it on the website, where you would be required to, in a sense, assess, diagnose, and initiate measures to stabilize the patient's condition before handing over to a specialist. So general medicine and neurology are an important subsection both in parts 2 and 3. And again, quoting directly from the website, this is going to test you on medical and neurological conditions which have associated ophthalmological signs and symptoms. But once again, medical emergencies, ophthalmic sequelae of treatment, how you would investigate and stabilize a patient prior to referring to a medical specialist are all important parts that you should be very well versed with. Some quick tips. In general, the exam is quite practical, and you don't need to know long lists of percentages and proportions or incidences and prevalences of different diseases. You would be asked very practical questions. And as Dr. Rohit sir said, your answer, even as in your MS and DNB, should be very methodical and planned. You would go from a condition that's life-threatening to one that is vision-threatening to something that's only of a cosmetic nature. But you would be asked subsequent subparts, or subsequent questions would be based on the answers that you give. So let's come to part 3, which is really the exam where people find a lot of variance with the Indian examinations, because this is something totally different, unlike your MS or DNB exam. So in the Viva, it's really a very quick exam. You have 3 tables, as I said, which cover lids, oculoplastics, and anterior segment in one station, posterior segment and glaucoma in a second, and neurology, motility, and general medicine in a third. So you can see that you need to pass in all 3 stations individually, including parts that you may have been tempted to leave alone in your MS or DNB, which includes neurology and ocular motility. And you are going to be examined by 2 examiners, one at a time, and they would then their marks would then be moderated by the exam moderator. So there would be a good amount of objectivity in the examination. It's a structured exam, which means that the examiners are not going to ask you questions at the top of their hats. There are no pet questions of the examiner that you need to know before you enter the examination hall. The examiners have a specific question set with model answers. And if you hit those keywords, they will have no choice but to give you the marks. Generally, the questions are in the form of clinical situations or a picture or an investigation, where you would need to then start assessing and talking. So The clinical examination is conducted on a totally different day, with generally one day as a rest day in between. And here you have 4 stations, and you are going to examine patients in each of these stations. You have even less time. You have only 12 minutes at each station. Again, there would be 2 examiners. And on average, if you're able to see 3 or 4 patients in each station, that means you're doing well. You are not going to be asked to do a lot of history taking or very invasive examinations, or where you would have to touch the patient, or anything that would be very uncomfortable for the patient. But clinical techniques are going to be assessed, and clinical tests, which you should be very conversant with, are going to be looked at. So practice pays. These are some examples of some photographs of my convocation at Glasgow, and this was my study buddy, Dr. Asif Virani from Thane, who was really a major part in the success of my examination, including we used to practice on each other, doing the tests on each other, and discussing answers with each other. So if you have somebody who's giving the exam with you, it really makes a big difference. And some images from the beautiful convocation ceremony, which you can treat yourself to after you've completed your your exam successfully. So just some few brief ideas about why one would be tempted to give this exam. If you are planning to emigrate, you don't need to give the PLAB, which is a great boon for an ophthalmologist. You don't need to now study general anatomy, physiology, biochemistry, pharmacology, etc. You can directly register with the GMC. As Dr. Lalit Verma sir mentioned, that there would be potential for a better emolument, whether it's within India or abroad. There are certain cross exemptions with ICO and other examinations if they are also part of your list. But generally, one gives these exams because one enjoys giving exams, or one wants to add to the prestige of your post-nominal initials. This is just an extreme example, but I would also at the same time, recommend that you don't give up after one part and then, use the term FRCS part 1 as your post-nominal initials. Go for it, finish all the 3 parts, and I'm sure you would be you would have a great feeling of achievement after you've done that. There are certain disadvantages. It is not a licensing examination, so you cannot therefore apply for a job as a specialist ophthalmologist anywhere. And they are expensive examinations, so you need to really think about it when you are entering the course. These are a few glimpses of the hands-on course that we do at Lakshmi Eye Institute, and I'll just put this up there for anybody who wishes to take a screenshot or note down the number. We are having this course just next month because it would be well in time for this year's examination, which is going to be held towards the end of September. So any candidates who are interested, definitely can join us. We have patients and interactive discussions, and we do a mock exam, so you get into the feel of how to appear for this examination. I wish everybody who's giving this examination all the very best, and we'll be happy to interact with you either over mail or in person. Thank you so much.
Thank you, sir. Thank you for giving all the details, some practical tips, and some strategy that one can develop to, clear this examination. Can I have a quick comment from Dr. Pranita if she is there?
In fact, Pranita will be our faculty for this course this year. We're very
Okay,
happy to
great.
welcome her into the course as well.
Yes, so I'm happy that this time, as Dr. Devendra has been doing this course for a long time, I'll be joining him in this course as a faculty for the first time. And I hope that we have more delegates who are looking at this webinar join us for this hands-on session.
I also want to just add one more thing, that for this year, we are going to have a hybrid course where while Lakshmi Eye Institute will continue to have the in-person course, we're going to have an online course so that we're going to cover many more topics than what we can otherwise in 48 hours. So I think that's something Devendra will pass on all the information very soon.
We also have Dr. Rohit Shetty, sir, again, a very prominent luminary. Sir, good evening and welcome. Your comment on FRCS, sir, before we proceed. Why should we spend money on that?
Being on both sides, both as a student who took up FRCS many years back, and also now an examiner, both international and national, I think FRCS in many ways helps us to look at many things holistically. It's not just an exam. Many things we assume we know, right? For example, a simple refraction or seeing a fundus, and how in that few minutes, how a brain thought process can wire differently. The cases in FRCS is never tough. In fact, if we get the same cases in MS, most of us here would get gold medal. But the people who fail in FRCS fail because of simplest of cases. For example, a simple RP, retinitis pigmentosa, which is as soon as you see the fundus, you see it you see it clearly, or a corneal healed corneal ulcers. We don't keep those cases in our MS exams or DNB exams. We want more tougher cases. The system of examination is so different, and that is because they just want you to understand the whole thought flow or flows of how you are thinking, how you flow is when you are examining a patient. And sometimes people do make mistakes, and many times we have seen that those make people who made mistakes. But if the flow of thought is right, the co-examiners, the senior British examiners, had given them very good marks, even though they had missed the vital finding, and which probably we don't see that kind of thing happening in our examination system.
Thank you, sir.
Like you said, I think so. The international examiners have a more forgiving heart.
I don't know whether they have a forgiving heart or not, but the way they examine a student is totally different. You're not examined by what you don't know. You're examined by how much what you know and how well you know about that area of questioning they have,
So the
which
not the final diagnosis on which they lay the importance
absolutely,
of how you examine the patient, how you interact with them, and that is what is held of prime importance probably.
absolutely.
Thank you, sir. So with this, we move on to the next topic. And now we have Dr. Rashmi Gandhi, the guru of neuro-ophthalmology. Those who have a little connection with Chennai, we know that neuro-ophthalmology for all of us, where it was all about Naveen Jayakumar and Dr. Rashmin sir. So sir is like known for his remarkable clinical acumen. And today he's going to talk about a very, thought-provoking topic. In fact, can or will AI impact me or my practice? So over to you, sir.
Thank you, Mamta. Thank you so much. Thank you once again, Deepak, for having me here. So yeah, this is in a way a very different kind of era that we all are fortunate or unfortunate to be in, where probably for the first time, humankind, it appears that humankind probably would encounter a species or a system which would overtake humankind in intellect. And there is a lot of excitement and also scary portion is that we really don't know, or I don't think we are prepared how to handle it. But that's something which is much larger problem. Right now, we're going to talk about how we can utilize what we have available as AI. Now, initially it started, ChatGPT is one of the artificial, and I'm just going to talk about this as if a lot of you probably have not experienced this fully. So ChatGPT is one of the first models which came out in November 2022, and a lot of it was being used or is being used for more fun. Like, here we are giving a prompt to ChatGPT that write a poem on neuro-ophthalmology, and the style of poem should be as if Shakespeare has written a poem. And you see, and these are very early models of ChatGPT. This was done in 2023. And the way you see, it has really written a beautiful poem. It has written a poem on neuro-ophthalmology, and also the style is very Shakespearean. So the first question is how ChatGPT or artificial intelligence is different from Google. What is the difference? So here I wrote down the management of optic neuritis, and I searched it on Google, and this is what it served me. I mean, a lot of pages, as we know, on optic neuritis, and we need to then go and select appropriate page that we feel would be useful for us. versus the same prompt. I gave it in artificial intelligence, and it gave me a beautiful paper where it says that this is an expert level summary tailored for clinicians about management of optic neuritis, and it sort of goes point wise. What should be the initial assessment? What should be the workup? What all tests that you should do? So that's the vital difference. Google is almost like, you think about having a particular, let's say, a particular dish, and then ChatGPT is like a cuisine which is in front of you. Google is like a cuisine is in front of you, and ChatGPT is like a perfect thali which is served on platter to you. So the ChatGPT was one of the first model which came out, and that's why it is more popular. But these are the language models that I personally use. Claude, somebody who wants to do a work on, let's say, preparing a business report or more formal financial calculation, Claude is really a very good model to work on. Claude has been launched by a company called Anthropic, and it is believed that this is probably the most ethical, if you want to use that word, company in the AI space, because they are really worried and looking at the safety of developing this model. So they are not really going all out to develop a model just to beat the competition, but they're looking at it from the safety perspective. Grammarly and Quillbot, and I'll demonstrate its use in the next video. They're very good, and these can be actually integrated to your browsers, to your Gmail, to your WhatsApp, and you can actually correct your whatever message that you're typing on various platform live. Grok, and I'm going to again demonstrate. Grok recently came up with their new model around 10 days ago or 20 days ago, Grok 4, and that has really advanced the capability of some of these models. So that's about different models. I mean, there are a few more which I've not. There is a model called Quen, which is published by Alibaba, obviously because its origin is Chinese. So there have been some debate about the data security, but Quen is very good in what we'll discuss a little later about agentic AI. And Meta, of course, has its own model as well. So what, as a student, what all we can do, and of course, the ethics of this can be discussed, whether should, as a student or as a researcher, should we be allowed to use AI to create an article by itself? But well, there's something which I feel genie is already out of the bottle, so I really don't think we can contain it because it's all available there. So unless there are very strict regulations of its usage, it might as well that we learn to use it till it's allowed. And so to create an article, there is a AI model called Storm, and this has been published by Stanford University. And let's see how does it work. And here you see, I've also used Grammarly and Quillbot as part of my keyboard so that I can correct. And it is already asking me to correct my prompt, which I corrected. So this is Grammarly. This is Quillbot. You can paraphrase also if you want to paraphrase using Quillbot. And I've done that. And now this Storm, the advantage of Storm is that it really looks at the web. It tells you the references as to what references it has looked at to create your article. So it does make your job very easy. So here you can see it has started browsing the internet for what's new in neuro-ophthalmology. And these are the various websites that it has looked at. It tells you that these are the websites it has gone through, and then it will create a very beautiful article, which then obviously it has not reached a stage, especially in healthcare or in ophthalmology, where you can just use what is being served to you. You have to still go through the entire article and make sure that there are no mistakes, because especially in biology and in healthcare, AI is liable to hallucinate quite a bit. So here it went through those steps, and he says that now I keep saying he, I don't know whether AI is he or she, maybe she. So it has now started writing the article, and here it has written a beautiful summary of the article of what's new in neuro-ophthalmology, completed with the references which it has given. So that's about Storm. Now, what about day-to-day life? Can we use AI? And here I've given you some example. This is a very beautiful tool which is now being embedded in Gmail. So, for example, here I am supposed to write a reply to Dr. Ajanta Keshavraj, and this is what I typed in my Gmail. And you see, there's a lot of spelling mistakes. I've missed out N here. The grammar is not up to the mark. There are like some gibberish words that I purposely typed. And then on Gmail, if you see, there is a symbol like this, and there it allows you to either polish what you wrote, you can formalize it, you can make it lengthier, or you can make it shorter. And see how beautifully it. This is what I had written, and this is what Gmail told me I should write. Dear Dr. Keshavraj, instead of Ajanta, it actually formalized it a little bit, and it said, "Thank you for kind invitation. I truly enjoyed being part of the meeting. And thank you, Dr. Thomas." Complete with all grammatical corrections. Similarly here, and this system really learns your personality. So here you know that this is my research collaborator, and so here it was very formal to say, "Dear Dr. Keshavraj," and here in itself it says, "Hi Kavita," and said I says they have a complete eye checkup somewhere, and it made it beautiful. "Regarding your query about the Vishuddha, I recommend the individuals undergo complete eye checkup." So this is something which can be used very easily, and as I said, it's part of Gmail. If you don't use Gmail, then other emails you can use AI like Grammarly in your like you say here. I use this on my mobile phone, so you can use some of these AI on your mobile phone as part of your keyboard, and it will correct it as you go. All right. So now I said Grok came up with their latest model very recently, and it is supposed to be very good to read the images. So I fed this image to Grok to say, just read this image and generate report of case 1. I didn't give any other details to it, and see what it has done. It says case ID case 1, date of examination not specified, and it on its own, it says appears to be static perimetry test, for example, Humphrey visual test. And see how it has generated the report. So this is, as I said, without any other prompt, just that picture. And he says that left eye, there is a dense absolute defect in the temporal hemifield, manifesting as a large black region. The nasal hemifield on the right side of the plot is largely preserved. The defect sharply respects the vertical midline and no other defect. So beautiful. It has sort of looked at the positive and negative findings. More importantly, if you really look at, I'm sorry for that, look at what it has done in the right eye. Not only that, it told me that there is also dense absolute defect on the temporal and hemifield. The nasal hemifield is set. Similar to OS, it respects the vertical midline. However, the most important part, it says that there is no significant superior or inferior defect noted, because that's what we look for in a temporal hemianopia to say, to find out where the defect is originated from. So interpretation, this bitemporal hemianopia, recommendation, urgent neuroimaging, endocrine evaluation, follow-up testing, clinical correlation, and referral to neuro-ophthalmology neurosurgery. So it has come up with a beautiful report of a visual field, which a general ophthalmologist who may not have an exposure to a neuro-ophthalmic diseases can use this to give it to the patient, which can be. So it in a way, it not only helped us clinically, but also helped us in computational, and also helped us to create this report, which otherwise we sometimes don't create ourselves. So if this is the level of detailing AI can supply us in a practice, would you really say that the knowledge and the skill, which is right now a differentiator between two people practicing or two institutions practicing, can knowledge and skill be taken as a differentiator? Has AI made knowledge a commodity, which is available to anybody who is willing to look at it on his phone, and that thereby really making an experience and knowledge defunct? No, we have not reached there as yet, because we still need to know how to use these things, and also most of these models are not foolproof. So it will, and as I'll show you, it can make very silly mistakes. So it has not really reached a level. So where else it can go? What else AI can offer us? So what we have shown so far, they are all called language models. So from zero, we have used language models, and there are so many language models which have come up. Now we are going to what is known as agentic AI, or AI agents. So from language now we are asking this AI to choose logic. So language model, as I said, is I can type in a language model that suggests a good South Indian breakfast for me, and it will come up with suggestion. This is what you can do. A logic and agentic AI, when trained well, would actually end up ordering a South Indian breakfast. When you say that I want a South Indian breakfast, but under 50 rupees, it will search your area. And it has now, a lot of these agents have a capability of making a phone call on your behalf, actually sounding like you, to order a breakfast for you. So, and what next? So that's already in the offing. A lot of these models are already available, which have been used as a customer service agent by business houses. What next? The ultimate, it appears right now, ultimate aim of the artificial intelligence is to reach super intelligence, or what is also known as singularity. And if you are interested in this topic, I would suggest this guy. He was with Google, Ray Kurzweil. In 2004-5, he had predicted, and he said at that time he published a book called "Singularity is Near," and now he published recently, last year he published a book called "Is Nearer." What is singularity? When we merge with AI, and when basically our brain is hampered, if you want to use that word, by our biological limitations and our genetic limitations. So what people like him say is that we can overcome these limitations by using these artificial intelligence, which can compute way faster than what we can, or look at the knowledge way faster than we can. And what are the examples of AI superseding our work? Recently, this is February 2025, the scientists were looking at this superbug problem for many years. And this is Google AI model. I think it's called Google Science. It cracks this problem in 2 days. Another interesting, these are run-of-the-mill thing of AI algorithms being used in ophthalmology for glaucoma, diabetic retinopathy, and whatnot. But let me stick to something more exciting which is going on. So this is there is a game, Chinese game, which is 2,000 years old, called AlphaGo. DeepMind from Google trained a model to be expert in this game called AlphaGo. It requires a lot of mathematical calculations. In little time, AlphaGo became an expert, and actually it defeated all the champions of the game available during that period. However, what was more interesting and maybe scary was AlphaGo came up with a move in DeepMind came up with a move in AlphaGo, which was completely new move in a 2,000-year-old game. So in other words, it appears that AI seemed to be knowing or seeing something a little more, because it can calculate the data so fast. I mean, a data that might take many decades for us to look at and calculate and interpret. AI can do it in the matter of few seconds. So that's the reason why it can be used. This power can be harnessed. Just imagine you feed a lot of data, videos, and AI is part of your microscope when you're doing a cataract surgery, and it can tell you precisely, looking at the signs that we are not aware of, to say that you are now in a red zone where a PC rent is imminent. Now, that's the kind of stuff that AI can do. This is already being used by a few companies which have merged AI with quantum computing to actually bypass the entire drug discovery process. To say you don't have to go through such a long process to discover a new drug, but you can use the AI computing and quantum computing to discover new drugs. So what else it can do in ophthalmology? Well, completely disruptive transformation, like what Elon Musk said on 10 July when he released that Grok 4, saying that it might actually discover new physics by next year and new concepts. So in ophthalmology, for example, right now, all our equipment, all our concepts are based on the concept of light, and say that light is both wave and particle. In other words, we really don't understand light so well. There's a possibility that AI will change our understanding of light, and all our future equipment, diagnostic or therapeutic, might be based on that new understanding of light. And that can be, that kind of disruptive transformation can come about in ophthalmology. So is it all hunky-dory? No. We don't really, can we trust AI decisions? Certainly not at this moment. Are there any problems? Yes. AI, generally it is believed that learns in a language, like for example here in English, but it appears that it starts designing its own language, devising its own language, and two AI agents. There are videos on YouTube which they communicate with each other in a language that we don't understand. Now that's very scary, because if we don't know how AI reaches from point A to point B, we would not be able to stop it if we have to, if it goes out of hand. And that's something which is a major drawback on AI. And that's something which is fueling, actually, if you really look at it, the current geopolitical upheaval that you're seeing everywhere is probably related to that, because the country that reaches the super intelligence first would actually control a lot of resources and knowledge of the world. And two limiting factors for us is genetics. For AI, it's nanochips and power and electricity, and that's where all this wars and realignment of power which is happening. So I'll conclude with this saying why ChatGPT, at least for now, will not replace the doctors. This is a picture which was shown to ChatGPT saying what is happening in this diagram, and this is obviously a urethroscopy through penis, and what it says is this is a nasal endoscopic procedure or a transnasal endoscopic surgery. So we have not reached a stage where we can trust AI complete, but it's exciting for the potential it was showing. Thank you so much.
Thank you, sir. Thank you for this wonderful, insightful talk. And we all have been using ChatGPT or these softwares, these apps in one way or another. But this is like describing a totally new dimension of it. We all have been hearing about machine learning, but this is totally new for me, at least. So can I have a quick comment from Dr. Akshay Nair if he's there?
Yeah. Firstly, as a oculoplastic surgeon doing endoscopic DCR, I take offense to that image. Yeah, I think it's only going to get better. A lot of people are in denial, and they want to remain in the old school way in terms of analyzing data, in terms of assessing and understanding what that entire data set means. But even if you just to take it an extra step forward, even if you have an Excel sheet with actual clinical data written on the columns, on the headings, your advanced learning models can actually look at factors that you may have overlooked. The same thing, and I know as all of us are, I can see on the panel, Dr. Rohit Shetty, Deepak, Dr. Ashwin themselves and Dr. Rohit, extremely well-established academicians who are reviewers for a lot of journals. But another place where this really helps in expediting, and I know I'm letting the cat out of the bag, is uploading the, in helping you refine your analysis or review of a paper. So, while it can do it completely, it's good to go through yourself and give the human touch, and then look at things that you can improve. So it's only going to get better from here. And I'm sure it's a matter of time that journals submission websites will also have very robust AI detection tools. I don't know whether, ethically are we still okay to have AI helping you write manuscripts, or is it still taboo? Because at the end of the day, the product, if the final product is scientifically sound, it is helping progress science. So that's a little bit of a gray area. But yeah, the future is here already, and those who miss the bandwagon will miss it.
Don't you think it's time that we stop being, shying away from it? Yeah. Just, start
Absolutely.
accepting it. Yeah.
100%.
Great. So with this, shall we move to the next talk, Dr. Deepak?
Yes, sir.
So next we
Next
have,
talk is
please.
Next talk is by Dr. Professor Rohit Shetty, sir. He's the one person who each and everyone like to be at least attend his one conference or meet once. And the viewers, I am telling you, all of you are lucky that he is here, and he's going to tell you something which is not only he's having an extraordinary mind for each and everything's new. Means I can say one person who can see the future of the ophthalmology is Dr. Rohit Shetty, sir. Rohit, sir, I'm not going long between you and your viewers. Just, sir, please.
Thank you. So, I'll be just having no slides because I'm not in Bangalore. So and the connection here is not so good. I thank Dr. Rashmin, sir, because a lot of things you discussed is exactly the slides I would have made, especially the last few things: knowledge and skill disruptor and disruption technologies, disruptive transformations. These are the two important words which I'd like to start off. And also thank the dynamic chairman, Dr. Prashant sir, and Deepak, and all the team here. One very important lesson I learned during the very initial part of my journey is your medicine is not an extension of your past or present. This was in the very early 2000. And I realized that it has such a strong impact on me that what you think is going to be that just an extension. That time we were doing FICS had just come into the picture. ECC was just the raging king then. And then FICO had already started, but very few pockets. The people who started FICO then were considered disruptors because many people said it just is not going to the way. India is not about FICO. India is about SICS. Of course, that debate can go on, what is good and bad. I'm not getting into that. But the people who had the guts to accept that as a disruptor and face it, I think are probably the leading surgeons of today. I'm sure a lot of them are in this, and same applies to retina, same applies to every technologies. When we start looking at disruptive technologies and transformation, the classic one is the one we are using the model now, the Zoom. And Eric Yuan was rejected. He didn't know English. He was rejected 8-9 times to reach US. Finally, he worked. The story is saying that he had difficulty communicating with his wife or girlfriend then. And he felt that there was no proper communication where he could see the different stories, whether it's true or false. Then he built something which he created, something which is what we use now. And it is just a thought process. He was not a disruptor. WebEx and Cisco was a disruptors. The later, I mean, he made it easy compared to it's every man's place. So what is important here is in medicine and ophthalmology today, like what Dr. Rashmin mentioned, knowing things, what happens in fellowship is, our fellowships is a lot like our engineering college syllabus. If you look at the syllabus now, some colleges are getting better, but if you look at the best college of syllabus, the syllabus is outdated to face the real world. Our fellowships, I'm not talking about PG. PG, you have to have structure. You have to start with basic. But our fellowship structure today, which is the next step to become a consultant, I feel is still very rudimentary and still stuck to old age because nobody wants to be a disruptor. When you say disruption, how much of AI are we teaching? My patients who come today, even today morning, I had a patient who said, I have taken 5 opinions. I said, which doctors? And she then had a shy smile. And she had said, I've taken opinions from 3 AI models. We are not going to get people who are going to get opinions from doctors. We're going to get people now who are going to get opinion from different models of AI. The question is, I'm not ready to face this kind of patients. And now, like Dr. Rashmin said, this AI model is fantastic. It tells the patient that your ACD, the anterior chamber depth is 2.9. You cannot put an ICL because according to the FDA, the ACD has to be 3.2. And it did not give we don't have an Indian publication which says that people can say I can put for 2.7, but where is the proof? So tomorrow, she will take out those papers and go to court if something happens, say that I have put something without a proof. The first question is, are we ready for this? No, we don't know anything about it. We don't want to go to sessions which talks about AI. We learn superficially and go. The second, are we teaching the modern imaging properly? No. we are just superficially teaching the students. Are we teaching immunology? There is a very nice Nature Science cover page article, this issue. It's about inflammation and body. He talks about every single organ from the head to toe, how inflammation is changing the entire dynamics of our human body, and we have no idea about it. What are we teaching is skill and surgery, which is the end. I don't even think it's just the very superficial part of it. Because if you look at patients in, say, when 25 years back, you do a PRK procedures. Out of 100 PRK procedures, you treat minus 10, 11. Dr. Daljit Singh had published about treating 20. And he said he had no scarring because your body's immunology was different. Today's immunology is different. And we are not teaching anyone any of these things. So the first thing is your medicine is going to be drastically changed in the next 10 years, and we are not ready for it. Why we are not ready for it is all fellowship programs are extremely shy to bring in new concepts, bring in new ideas. So what is research in many times is just go back to PubMed and pick up some article and let's do. PubMed is not the way to do research. PubMed is to give you an idea about how people are thinking. If you think the way exactly like the PubMed, then you're copying. Then you'll never move forward. That is the first level of disruption. The second is the word research has to be defined differently. Research is not just making an extension of your thesis in your post graduation or picking up something here and there. Research is what happens on everyday practice. Research is about one patient who sits in front of you. You've done a cataract and he's not happy, and the other 99 are happy. That one person becomes your research. But we are being taught opposite. One is statistically insignificant, 99 is statistically significant, the p-value is very good, my results are very good. So what happens is you don't become a disruptor. What we do in research is that one person who is not doing well is a disruptive research. So we spend a whole day on that one person, because when you pick up that one person, tomorrow you'll figure out a completely new dimension of research. The third is, when you say research, maybe when we were postgraduates, research was purely done as a full-time by somebody. When I was a medical student, we'll say, oh, this guy's a great researcher, but he's not a good surgeon. So it has been drilled in our mind that if you can't operate or you have a heavy complication, whether you're a surgeon or you're a physician or a gynecologist, you become a researcher. That is like a graveyard for people who can't operate or who is not a good clinician or who not a. But today, in disruptive science, what we created is you should be a fantastic surgeon, a good physician, and you can merge a healthy merge between research and science. So that becomes what you call it the PhD program. So when I talk about the PhD program, people say, "So, sir, I don't want to do it because I don't want to do only research." I said, "Who is doing only research? We all operate 6-7 hours a day. Every surgery I operate, I think about a PhD topic because I know there's something gone wrong. The flap is very weak, or I get a patient who's got a developed an ectasia, or something happens, or cornea is something else." So disruption is a state of mind, because you cannot say I'll be a disruptor and start working from tomorrow. Disruptive thought process is a state of mind which has to be all time on. You're not that you are against the process or anything. You're not fighting about anybody. You're not fighting against anybody. You're just the thought process is like that, and every thought process can come anytime. For example, a very nice story about the man who discovered insulin, the Benting and Best, and one of them, I think. And what happened was when he was giving a talk about he was doing a lot of work on diabetes, and he had no idea how to find a solution. What is the solution of cure? And he was hell bent on it. So when he was doing a talk in a college, like a keynote address somewhere, he suddenly got an idea that if he can isolate whatever the pancreas secretes, that isolation might actually end up finding a cure. So he stopped his talk. He took a paper. He wrote down on the slip of paper, isolate the pancreatic duct, wait for what the insulin islets of pancreas secretes, dot, 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 identify that isolated thing, dot, 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 and there you find the answer. And he scribbled it, put it in his pocket. People thought he was trying to find some thought process. He went back, he re-looked at the same thing. Next day morning, he went, applied for a grant, got some docs who he developed pancreas. He did the ice. He ligated the pancreatic ducts, blocked it. So and then made sure whatever, and then identified those cells, got the insulin, injected the insulin back to these dogs, and cured. And that's what became the insulin today. So what I'm trying to say is, you don't need to have a PhD or register you're into anything. Disruptive thought is a state of mind. It can happen anytime. When it happens anytime, make a questions. These are the question I want to ask. If you have a question, you'll always find set of people who will be ready to answer your questions. So I would like to end my talk here. A simple process. And thanks, Dr. Rashmin, because you covered a lot of good aspects of it, which is very, very nicely summed up. So I don't want to go into those things. Think that what you practice today is not going to be there tomorrow. So be involved, figure out from different fellowship programs. That's the reason I just posted in my social media just 2 days back. We changed that whole program of our fellowships. But my fellowships does not have a structure anymore. We included AI. We included applied optics, my a lot of fellows said, I don't want to. I said, if you don't want, it's up to you, okay. But in next 10 years, you'll have to go back and learn from somewhere. That time you'll not have time to do all this. It's best to be incorporated. It's like learning alphabets when you are already in the 10th standard because you decided to skip it when you're in the first standard. So AI, deep learning, biology, biomarkers are going to be or gene therapy is going to be as important as learning skill today, because the next wave of therapies which are going to come is completely going to be a massive tsunami of these things, and it's already happening. It will pick up. So be ready for it, and all the best. Thank you, sir, for this opportunity.
Thank you. Thank you.
Thank you, sir, for as usual, wonderful and mind-blowing talk. Shan, sir, some comments, son.
As anticipated and as expected, sir, it was a disruptive talk, making people think much more beyond fellowship and much more beyond what is happening today. And I'm sure our students will be ignited, and rather I should say we will be thinking more so beyond fellowship, beyond studies, and how to think beyond what is routine. Thank you for inspiring our young students, sir, once more, and sparing your valuable time. I know how busy you are. And postgraduates, remember, Dr. Rohit Shetty comes with a prize. He has come with a prize that for all of you. So be thankful to him. Thank you, sir. Thank you.
Sir.
Thank you, sir.
Thank you so much.
So next we have Dr. Akshay Nair from Mumbai, and he is an expert of orbit and oculoplasty. He's going to talk about surgical training opportunities and observership abroad. So he's going to give us valuable insights about different international training programs, the different, observership opportunities that are available. So over to you, Dr. Akshay.
Thank you. I hope my slides are
He's,
visible.
he's proliferative author and very to find
Great.
even at midnight too. Dr.
Okay.
Akshay.
Sure.
Thank you so much, Dr. Deepak. So why, when we think of doing a fellowship abroad or an observership abroad, why do we do it? I think I had to wear my student cap and try to think of why. It's possibly because we assume or presume that possibly there's cutting edge training there. there are better research opportunities, or we could, use this as a stepping stone in case we are moving base and shifting completely to another different country. Oftentimes, we like to come back with the prestige of having trained abroad because we can write post-nominally, apart from the FRCS that Devendra has helped us navigate. We can write clinical fellowship USA or wherever, Switzerland or wherever it is. And also the networking opportunities, which surprisingly is an I'd say unsung hero. Networking, the opportunities to network and build your connections abroad is something that these fellowships and observerships truly bring about, and I'll explain in detail. When should you? I'm going to split the talk into two halves. One is surgical training opportunities abroad, and the other is observerships abroad or short-term fellowships abroad. So while we're talking about training in terms of surgical training, when should you not consider training abroad? When you're not sure of what you want to learn, when you have not analyzed your residency training, you have not figured out the gaps in your residency training. If you've done, say, 100 SICS and 10 FICOs, and you want to go abroad to do a refractive surgery fellowship, that's possibly not the next natural step. You want to step back, do something here, get proficient in what you want to do, and then build that as an additional qualification. When you've not completed your specialty training in India, or you're unsure whether you want to be a comprehensive ophthalmologist or you want to do a specialist, so super specialty training, or possibly you finished your fellowship, but you're unsure of what additional skills you want. Basically, when you don't know what you want, that is not a position where you want to just go abroad and take in whatever you're getting. Also, if you want to settle abroad, there are more conventional routes rather than doing an international fellowship and coming back. So training abroad, broadly, there is the UK, US, Singapore, Australia, then the ICO, the Ophthalmology Foundation, and then the societies of the Asia Pacific Academy of Ophthalmology and the Asia Pacific Society of Ophthalmic Plastic Reconstructive Surgery. So what UK has actually a very streamlined surgical training fellowship opportunities online. You have the NHS Jobs, which is an open website where you can even search without creating an account. Say, for example, you go in and type oculoplastic surgery and search everywhere. You would get different, opportunities where you can register. You look at what their requirements are. Here, for example, at the Barking-Havering Redbridge University, they want a specialty doctor in oculoplastics, whereas in the Royal Free London NHS Foundation, they want a senior fellow in oculoplastics. And then you need to click on them and see their requirements. So you need a GMC registration, for which you need an FRC off. And then you would have to also have, say, they may ask for additional experience in terms of medical retina. So you need to look at what skill sets you can offer and how you fit into their program. For the UK, getting a surgical training fellowship requires you to be registered in the GMC, for which an FRC off is the most optimal way. So basically, to train in the UK, you need GMC registrations, which basically requires you to complete your EPIC, which is called the Electronic Portfolio of International Credentials, complete your GMC registration, have 24 months of clinical experience. This, of course, even clinical experience in India counts. And despite having English as our first language, we need to have documentation of our proficiency in English language, for which you have the IELTS and other tests. So this is like a single screenshot of what it is to have your EPIC or Electronic Portfolio of International Credentials. You will need your degree, which is accepted by the GMC, which in this case would be FRC off. You need your IELTS or OET exam, where you need to show your proficiency. And additionally, of course, if you don't have your FRC off, you need to have your PLAB or USMLE, both of which are accepted there. And of course, like I mentioned, if you have your FRC off, then that allows you to bypass this. Additionally, you can also have the MTI or a dual sponsorship scheme. So the Royal College of Ophthalmologists offers this opportunity for international medical graduates to take specialty training here, provided you have dual sponsors, which means that you have to look for a center or a sponsor in the UK who would then connect with a sponsor or your mentor, or the when we say sponsor, it's not financial sponsorship, it's an endorsement sponsorship. So they will connect with your mentor here or your teacher here, speak to them, discuss your training. And once both understand that you have a certain level of training which is agreed upon, what your goals are, then they would both sponsor your training there. So the sponsor in India will verify your skills. You will have an interview. You need to give a letter of recommendation. The fellowship is usually for 24 months with the expectation that you are going to come back. It also gives you the sponsorship for your spouse and family to come for the 2 years that you're there. However, there is a loophole where you can switch over to a work visa in the toward the end of this fellowship, and then go into the system as well as a locum, because there are, or even as a consultant if you have your FRCPath or adequate degree there. So there is a way that you could even migrate to the UK using this. Coming to the US, in the US, you really need, they're very clear that a residency in the US is required. You need to have your USMLE, which is the United States Medical Licensing Examination Clearance, or you could be given a state board medical license, which comes at a residency waiver, which means that a lot of our colleagues in India have moved to the US, and they've been offered what is called a O category visa, which is a visa for extraordinary skills. And the state board gives them a residency waiver where they can go. But this, of course, comes at a much later stage in your career, where you've had a large body of work, which speaks for itself in terms of research and clinical achievements. There are certain states like California, Kentucky, Idaho, Iowa, and the ones listed here, where you can do a fellowship even without having the MLE clearance, provided it's for a short term and you go back, because they do not allow you to switch over to a working visa there. There are certain institutes, and of course, being an oculoplastic surgeon, I know better about these. The University of California in San Diego and the University of California in Los Angeles, both of them have very good oculoplastic and orbital surgery departments, where they allow 1 year international fellowships to fellows to train, where they also get surgical hands-on. These are very competitive fellowships, which are sought after by trainees from across the world. So you really have to build your profile, and they prefer people who finished a clinical fellowship in oculoplastics in their home country before having applied for this. In the East Asia, you've got two large hospitals in Singapore, NUHS and SNAC. Both do offer 1 year or 15-month fellowships in all specialties, which are marked as international fellowships, which do offer you a certain amount of surgical training under supervision of your mentor. And both these institutes have the details on their websites. Your Indian degree or Indian specialty is valid there. They are also open to taking in fresh residents. Not necessarily that you need to have finished a clinical fellowship here and then have to apply there. For Australia, the Royal College of Australia, New Zealand, the Royal Australian New Zealand College of Ophthalmologists website, RANSCO, has all the details on international fellowship vacancies. They're again very competitive, with most of them coming from Asia. They do require a licensing exam, so you need to have finished that. Certain hospitals in the UK and also in the US have direct hospital applications where you can bypass the system of the MLE or the Royal College of Ophthalmologists and directly apply to them. They are slightly flexible, especially in terms of say medical retina, ocular genetics, or ocular oncology, where not so much of surgical hands-on skills are required. Now I move into the observership part of my talk, where observerships abroad are extremely useful after having finished your surgical fellowships here. Because at that stage, I have done what I have done, I know what I know. And at this stage in your career, you can see that when there's a surgery being done, the observing that surgery there, you can mentally figure out, yes, I can do this when I go there. So at least you can learn surgical tips from there. And in this scenario, 3 months is enough. And I keep telling this, it's not the science, it's not the surgery, it's not the clinical examination or clinical skills that you're learning there. It's beyond that. It's about how to use new instrumentation, look at the OR protocols there, understand how they archive and retrieve data, things like patient photography or investigations like FFA, and how they archive all of that, retrieve that and analyze that. Soft skill, learning how to empathize with the patient, spend more chair time, understanding the SOPs in their clinic, the flow of the patient once the patient enters the clinic, counseling them, understanding the risks and benefit. These are things that, in a government college, all of this happens within 2 minutes of you seeing the patient, telling them, and then having them leave. That doesn't work in private practice, especially when you go into a corporate practice. So these are things that you really learn, modify, and adapt to how you can do it here. And these things really are very helpful. There are two large groups that offer these kind of 3-month fellowships. The ICO, the International Council of Ophthalmology, has their standard 3-month fellowship across 20 subspecialties in ophthalmology. They also have a glaucoma 3-month fellowship in association with the WGA. They have a 1-year NEI genetics fellowships. You also have a 1-year AbbVie advanced research fellowships. And you also have the retina fellowship, which is again a 1-year fellowship. Uh, they have a directory on the ICO exam websites with the list of hosts, the institutes that support the acceptance of these of trainees from other countries. But if there is an institute that you would like to visit that's not in the list, you can actually directly approach them and say, I want to go here. And they'd say, okay, just send me a letter of them accepting you as an observer for 3 months. We'll be happy to support that. Now, while the ICO website says clearly that it is preferred that you have cleared all the ICO exams before applying for a fellowship, it is ideally better that you do this, because imagine there are a lot of trainees or students applying for these fellowships, and the only thing that sets you apart from someone who's not taken the exam is you having taken them. So it is a slightly expensive investment, but of course you get the post-nominal initials, and also you get a preference in the allotment of a fellowship. The Ophthalmology Foundation also, which of course used to be a breakaway from the WOC and ICO, has 3-month fellowships where they offer up to 6,000 USD or 5,000 euros, the same amount that the ICO also offers for these 3-month fellowships. You also have a 6-month fellowship in retinoblastoma, and the International Ophthalmology Foundation Retina Research Foundation, Helmerich International Fellowship, which is for retina and for 1 year. They support all of them. The OF also has now their own set of examinations. They are growing in popularity, but I do believe for the next 1 or 2 years, you may still get awarded a fellowship without having taken their exams. Of course, if you do apply for a fellowship after having cleared all their exams, you have a much better chance. Again, as is with the ICO, the same thing with the Ophthalmology Foundation. If you have, say, seen a hospital that does the kind of research you want to do, or does the kind of work that you want to do when you come back, you can write to that institute, get their acceptance of fellowship, and come to them and say, this is an institute, I want to go here, and I'm going to come back to my country and carry on the work that I've learned there. They'll be happy to support that, even though it may not be in their list of hosts. So, this is very important. You need to ask yourselves before finalizing where to go and when to go for what you need to do. What are the skills you want to acquire? What do you want to be able to do with that when you come back? And what are the practical implications of this? Like I said, it could be a mentor. You may have seen, say, there's Dr. Harminder Dua in the UK, or there's Raman Malhotra, or there's now Jay Chablani, who's gone to the US, and they do such great work in very niche areas. It could be a mentor. Say, for example, I'm sure there are trainees abroad who want to come to NN and do the same with Dr. Rohit Shetty. It could be a particular mentor who's doing focused research. It could be a center that's a great collaborative center, or even a subspecialty. That could be the area of interest, and then you build upon that. And these questions are actually also there in the ICO fellowship application form, as well as the OF application form. So not just figuratively and metaphorically, you literally have to know the answers to these questions and put pen to paper when you're submitting the applications for these. When should you not do an observership? Just after residency, because at that point you're a little lost. It's good to do a fellowship here, or if you know that you are going to be a comprehensive ophthalmologist, then you can definitely look for it. If you're just looking for a paid vacation along with the conference, or just because everyone else is doing it, don't do it. You really have to harness the power of this short observership or fellowship and make it what you want to do. A couple of slides on my personal experience. This was, of course, a long time ago, 11 years ago, when I went as an ICO fellow to the New York Eye and Ear Infirmary. My mentor there, late Dr. Robert Della Rocca, in the white hair and white apron below, giving me my fellowship certificate, he realized I had an interest in retinoblastoma. He arranged for me to spend a few weeks with Dr. David Abramson, who's the father of intra-arterial chemotherapy in retinoblastoma at Weill Cornell and Memorial Sloan Kettering. These are the other international fellows who are with me. The networking really helps. I was made a regular fellow and had to do presentations and cases like the others were doing. It helped in many ways. You have to be focused. In those 4 months, I ended up writing 4 papers which were published in different journals. It was through the networks that I built that I was recommended as a member to be inducted in the American Society of Ophthalmic Plastic Reconstructive Surgery. Only the 4th Indian in 70 years to be inducted. So, it's the butterfly effect. Small things lead to another. Networks build. You meet more people, and that's how you build your practice, your skill set, and your name and reputation. Things to remember is make sure that the terms and conditions of each of these observerships and fellowships is clear about the funding. Make sure you have the required visa for that. Plan it with the appropriate timeline. Most of these fellowship timelines are a year or 24 months in advance. So if you apply for now, most likely you'll be offered an observership or a fellowship in 27 or 28. So think of these things during your PG. And as a resident, try to get involved in as many publications or presentation at conferences everywhere. Maintain a meticulous logbook. Every case that you've done, you've seen, you're assisted, you're observed, make a note of it, because that helps in making your application when you plan to apply for these fellowships. The AAO also has a global directory of training opportunities, including fellowships, surgical fellowships, clinical fellowships, and observerships. So you can log in as an AAO member and look at all of these, and you can search by subspecialties and by countries as well. Thank you so much to Dr. Deepak Mishra for the invitation, and Dr. Prashant Bankole for the constant support and allowing me to present this.
Thank you, Dr. Akshay, for such a clear, lucid, and precise talk. And I hope it must be very useful for everyone, those who are looking for opportunities abroad. So thank you again. And with this, we have come to the last talk of the evening by Dr. Pranitya Sahai, Assistant Professor, RPC. She is one young, dynamic talent who is just leaving her mark everywhere, just because of her academic brilliance. So over to you, Pranitya, and very warm welcome to you.
Thank you, ma'am. I think that's an overwhelming introduction for me. And at the outset, I would like to thank Dr. Prashant and Dr. Deepak Mishra, sir, for this opportunity to allow me to present. And without much delay, I'll be talking about FRC of the nuts and bolts. So we've already been discussing about FRCS, ICO, FAICO, and a lot of other exams. So to begin with, what is important is to understand what do you really want, whether you just want to go out for a fellowship, you want to settle abroad, or you want to just go abroad for your studies. So if you're looking out for a fellowship, just for a fellowship abroad, I think ICO is ICO, and off late the IOFF, the International Ophthalmology Foundation, which gives you a fellowship opportunity, both short-term 6 months and long-term 1 year, is what you should look at. However, if you're looking to settle in the UK, so FRCS and FRC off is something which is going to give you better opportunities, because that gives you an exemption to the PLAB exam and gives you an opportunity to register in the GMC register, which is important before you start your practice. Okay, so now I'll be discussing about the FRC of the exam. So this is the official website of FRCA, the Royal College of Ophthalmology, which gives you all the details about the examination, the dates, center, fees, the education material, and everything is there on this website. So the FRC of the exam is conducted by the Royal College of Ophthalmologists, which is based in London, and it consists of 4 steps. And once you have cleared all of these, you get the prestigious award of being called using the degree of RC Off. And successful candidates need to become a member before you can use this post-nominal acronym of FRC Off. This is also an exit exam for their own internal postgraduate students of ophthalmology. So anybody who's doing an ophthalmology in UK, this is their exit exam. So giving an FRC off definitely gives an advantage over and above FRCS, because this makes you equivalent to their postgraduates who are passing out from their country. However, there are additional things that you need to do before you get into the system. Now, these exams consist of 4 parts. The part 1 is a written and basic clinical sciences, followed by a refraction certificate and a part 2 written, both of which can be interchangeably written. It's not mandatory that you give the refraction certificate first, followed by the written, part 2 written. You can swap between the two. And all the 3 steps need to be cleared before you go on to the final part, which is the Viva and OSCE. For the first part, there is no minimum ophthalmic training that is required. And once you're writing the part 2 written, a minimum of 4 years of ophthalmology training is required. What is peculiar and unique to FRCPath is that you do not get any exemptions from either FRCS steps or ICO steps or FAICO. They have kept their own examination pattern very separate and apart from all the other examinations. So you have to give all the 4 steps to get the post-nominal acronym of FRCPath. Since it involves a lot of steps and a very detailed syllabus, it is important that you plan these exams well in advance if you really want to settle in UK and want to practice in UK. That is where this exam is going to be helpful for you. So the part 1 fellowship exam is an online proctored exam. So you can sit right here in India, and based on an online portal system, they have multiple examination centers which conduct these online paper, 2 papers consisting of 2 hours each with 90 questions each. And basically it confines to your basic and clinical sciences relevant to ophthalmology, wherein anatomy, physiology, optics, refraction, patient investigations is what is going to be asked. In addition to that, lasers, epidemiology, biostatistics, and basics of clinical genetics is also asked in these exams. The resources, AAO, Basic and Clinical Sciences course, the first 4 volumes, which gives you the anatomy and physiology of ophthalmology, and also certain investigations are covered, will be helpful in Adler's physiology. And Elkington for clinical optics is something which is very useful. Next, and the most difficult of all the 4 parts, is the refraction certificate examination. Now, the refraction certificate is what makes, again, this exam different from all the other exams, wherein while in other exams, your theoretical knowledge of optics refraction is assessed. Here, it's a practical-based exam wherein you have 10 stations of OSCE stations, wherein you are asked to perform retinoscopy, both doing a cycloplegic refraction and a non-cycloplegic refraction. You need to know a subjective refinement of cylinder, sphere, binocular balancing, photometry, and even prism power estimation in the spectacles is something that is asked in this exam, and it is a time-bound fashion. Every station has 10 minutes, so you need to be really quick while doing this practical examination. So it is unlikely you will pass this exam unless you have practiced extensively. A minimum of 100 refractions with all the steps practiced well in advance is something which is essential. I myself did at least 60 to 70 refractions over a month time before I was going to appear in the refraction certificate exam. And still you do not have any guarantee whether you're going to pass or not, because it requires extensive practice. So Elkington is really helpful, and there's another book by Park J which deals on how to pass the refraction certificate. That is really helpful with good tips on passing this examination. It's not just your refraction skills, but in addition to that, your hand hygiene, communication with the patient, and rapport and time management on which you're going to be assessed. So when you're doing a refraction, it's not that you can just go and grab the patient's head. You need to inform the patient, take consent before you touch the patient's head and perform a refraction. And all this is to be in a time-bound manner, where along with your refraction, you need to finish this station in 10 minutes. The next part is your Part 2 fellowship written exam, which is again an online proctored exam, can be given from India itself. It consists of 2 MCQ papers, 90 questions each, 2 hours exam. And this covers your entire subject of ophthalmology, and you need to be well versed. So it's just like your MD exams. While in MD or MS exam, you need to give theory. Here it's an MCQ based exam. So in addition to what we normally read for a postgraduate final exams, you also need to know about the good clinical practice patterns in the GMC practice patterns in UK. You have certain nice guidelines that are given in the NHS website. which gives you the basic practice guidelines that are used in UK. So if, for example, in a case of management of CNVM or a macular edema, there are cutoff guidelines of visual acuity where you inject anti-VEGF. For a driving license, their visual acuity cutoffs are different from India. And all that is what you need to read while going through the NHS website, looking into what is pertinent for ophthalmology point of view before you write these exams, because particular questions are asked about these steps, about these guidelines. Now, next is the part 2 fellowship oral examination. It consists of the structured viva and the OSCE exam. The best time to appear is during your fellowship or senior residency, because that is the time that your entire subject is fresh in your mind and you are well versed with all the specialities. So it is best that during your starting of your fellowship or senior residency, you give this exam. A minimum of 4 years of ophthalmology training is essential when you write this exam. And these are the stations of OSCE and Viva that you see. In Viva, it is important that in addition to the ophthalmology subject, there are stations of attitude, ethics, and responsibilities, and audit, research, and evidence practice and health promotion. Also in OSCE, other than the anterior posterior segment glaucoma, strabismus, and neuro-ophthalmology, that is something we usually see in our MD/MS exam, communication skill is one station which is important for you to pass. So in this, basically, there is a simulated patient. For example, in my exam, there was a patient who was injected anti-VEGF by a nursing staff. And on day 1 post-op, he developed a post-injection end-off. The patient was all agitated and shouting and screaming as if something wrong had happened with him. And my job was to counsel the patient. So the catch here was that you need to be aware of the UK guidelines. So you may end up saying that, okay, the nursing staff injected, it was wrong. But in UK guidelines, even a nursing staff can inject intravitreal injections. So that is where you need to know their guidelines, and then you counsel accordingly that, okay, everything, all protocols were followed still. Sometimes this complication can occur. And you need to pacify the patient. That is what is assessed. Sorry. So tips for passing up the exam is prepare the content and listing time. Plan well in advance. Sorry for my bad voice, I'm having a cough. So you need to read the Kansky and Oxford handbook, which is essential to read, and the Oxford Manual of Training of Ophthalmology is again important. The guidelines we have already discussed, the RCO guidelines and the GMC guidelines need to be read. And these are some of the books that you can refer to for your exam. The pass rate varies from 35 to 80%, and hence you need to be very well prepared. Sometimes the cutoff is as low as 40%. Hence, you need to prepare well in advance. Although there are multiple steps and attempts that are allowed, but the fees is exorbitant. The total fees for almost 4 steps is going to be approximately 4.5 lakhs. So you cannot afford to fail in these steps. You need to prepare very well so that you do not lose out on money as well as time and your effort. The fees keeps on varying from the country to country on which the exam is conducted, and also from year to year it keeps on varying. Even after you have passed all these exams, there is an annual subscription fees of almost 28,000 that you need to pay to maintain this post-nominal acronym. And once you have cleared all this exam, practicing ophthalmologist there in UK, for this you need to apply in the GMC register. And you can apply for fellowships as well as jobs, of which the opportunities are advertised in the NHS website. You can also apply to become an examiner in the FRCS. And I'm fortunate to be selected as an FRCS examiner this year. And hopefully I'm going to be a part of it in future as well. So it does give you a license to practice in UK, but you need to apply for it. And since it is a long step, so you need to plan well in advance. And these are some of the exams that I cleared during my senior residency and post-graduation. And this is a photograph from my graduation ceremony in London. And it is always good to have a study partner, as Dr. Devendra said, and my study partner, fortunately, was my husband. And it is never too late. So the last step of my RC off was when my daughter was 1 year old and she happened to attend the graduation ceremony at London along with me. So it's never too late. You can always keep learning and keep educating yourself and don't stop. So thank you.
Thank you, Dr. Pranita, for the clearing each and every point. And your last two slides was really inspiring, that anyone can attempt anything at any time. It's just your will is required, not the age or the anything issue. Okay, sir. So we completed all the talks for the today. Rasmin sir, you guided me to make the backbone of these things and the whole webinar. So now I see smile on your face. You are satisfied. What you can say?
Absolutely. First of all, the way you curated the whole program, and obviously the faculty that you've chosen, it was an amazing. I mean, I learned so much, so many things, and it's always pleasure to listen to all these stalwarts who are done so well. And I think that's the reason why you chose them, so that you can inspire the people who watch this to emulate them for success in their lives. So thank you, Deepak.
Thank you. Dr. Deven sir, one brief comment from you.
No, it was really well organized, and you've. I think for any postgraduate student, I wish during my post graduation I had exposure to so many different topics and avenues. I think the world is the oyster of this generation, and really the sky's the limit for what they can achieve and the options that are open for them.
Thank God, Devendra. You didn't have an option. Otherwise, I don't know how many more crowns you would have had in your.
No, no.
I don't think he stopped. I think he's still looking for some more four-letter words starting with F after his name.
No.
Good.
Yeah,
So
I think it's testament to Dr. Rashmin sir's mentorship, because Devendra and I both were residents who trained and were groomed by him in everything, not just neuro-ophthalmology, in ophthalmology, what in career guidance, and everything that we do now. He's always a part of it. To say in Hindi is unke hamare sar pe unka haath hai. So truly guided us, and forums like this.
Absolutely seconded.
No, and I need to add here that our granddaddy is Dr. Prashant Bhankule, because whatever I did was obviously because he was my mentor when I joined as a PG in Shankar Netralaya. So yeah.
see, as a mentor, my mentee does not have left any hairs left. So
That shows the amount of experience you have, sir.
You still have black hair. Dr. Rashmin has no hair, and Devendra has white hair. So I don't know what to make of this.
okay. So we had a wonderful discussion. I think, Deepak, we can sum up. We have already overshot the time. Yeah.
Yes. So on the behalf of whole FRCS team, we would like to thank you all the viewers. And sir, really, I didn't have any words to thank my speakers, because all are so, their time is so prestigious and so overburdened, but all on my one or two requests, all of you accepted it and make this program so lively and so useful that I can't thank you, sir. None of the speakers, just with folded hand, I say thank you. And also I would like to thank my co-moderator, Dr. Mamta, for most of the time, if network is here and there, she moderated so well. And the whole team of the Sunil and our AIS office personnel, Tushar. He is the person, he is a constant source. If I forget anything at 6 p.m., 5 p.m., he keep on reminding me, sir, it's time to join. Sir, it's time to that. With this, again, since you all are knowing that FRCS is conducting regular webinars for the postgraduates and ophthalmologists on the Thursday. So hope to see you all in next 4 Thursday, because my turn is given by my boss, Dr. Prashant sir, that you have to conduct next 4 webinars. So, sir, I'm also thankful that you have this opportunity.
Thank you.
And
thank you. In fact,
at
it
last,
is a
sir,
team effort.
with one story, I would like to thank. In the COVID time, I got some idea and contacted Rasmin sir. That sir, we want one article on this, the how important is the wet lab and this training for that, and the impact of webinars. And he turned me to that action hire. And that is the only article I have the maximum number of citation till date. And with the help of Nair, we all wrote it. And finally, it's really a great. Thank you, sir. Thank you, everyone.
Thank you. Chalo, it's time to say
Akshay, you are
bye-bye.
muted. Akshay.
I just said it's been cited almost 200 times.
100 times now. Yeah.
Yes.
Must be all the networking, Dr. Akshay, you have been talking about. Yeah. I can totally relate. Sorry. Thank you. Thank you so much, everyone.
Thank you, Sunil. Thank you,
Good
everyone.
Bye-bye.
session.
Bye-bye.
Good night. Good night, sir.
Right.